So this is a case, sir. My case is a 28-year-old gentleman. He's a carpenter by occupation. He's a resident of Roorkee, Uttarakhand. He presented with the chief complaints of mid upper abdominal pain with the duration of 3 years. And instead of presenting complaints, patient was apparently already 3 years back. He developed pain in the upper abdomen, which was dull aching type, which was mild to moderate in intensity to start with and it was radiating to back and was relieved with taking medication, that is painkillers, and was associated with nausea and there was occasional episodes of vomiting. Uh, it was pain was occasional to begin with, which was in the recurring at the interval of interval of once in 2 to 3 months. Now since the last 8 months, it has increased in it develops pain at 2 to 4 episodes per week. And there is a previous pain episodes used to get relieved on oral medication. Now, recently, he is requires IV analgesic for the pain relief. And patient on leading question, he gives history of passage of oily, greasy, bulky, foul-smelling stools in the last 6 months, and uh, during the last pain episode 6 months back, he was admitted to the local hospital where he was treated for the same, and he was started on capsules which were advised to be taken along with the meal. And the patient also gives history of 5 to 6 kg of weight loss over the last 6 months with decreased appetite only during the pain episodes. There is no history of jaundice, no history of hematemesis or melena, no history of any abdominal lump or fullness, no history of abdominal trauma. And there's no history of any dryness of eyes, decreased night vision, or bone pain or muscle weakness. Past history, history of previous hospitalization for the pain, that is 6 months back. He was received injectable treatment. However, there is no history of any ICU admission, and there was no previous history of any surgeries or intervention, and there is no history of diabetes or tuberculosis. Family history, nothing significant. The personal history, he consumes mixed diet with a normal bowel and bladder habits. Sleep is disturbed due to pain, and he is also active cigarette smoker for the past 10 years with 6 to 8 cigarettes per day. However, there is no history of any alcohol consumption. To summarize my history, is a 28-year-old male with a chronic active smoker with no comorbidities, having continuous dull aching type of pain confined to the epigastric region with radiates to back, uh, which has increased in severity in the last 6 months, 6 to 8 months, associated with loss of weight and history suggestive of steatorrhea. With this, at the end of my history, my provisional diagnosis would be a chronic pancreatitis, sir.
So you have only one diagnosis, or you want to have some differentials also?
Sir, peptic ulcer disease could be a possibility, but history of uh, weight loss and history of passage of oily stools. So this in more favor of uh, chronic pancreatitis.
So, are there some other diseases which can produce same type of issue? You are basing only on the based on the only steatoria that it is chronic pancreatitis. Obviously, when you are taking the history and associated all the findings, it seems that it is going in the favor of chronic pancreatitis. But for discussion point of view, are you aware of any other problem where same type of steatoria may be there, weight loss may be there? Okay, let's forget. Why did you ask the history of melena in this question when you are thinking about consent?
Sir, there could be associated complication of pancreatitis in the form of either by sinistal portal hypertension and varicose bleed.
So that could be the portal hypertension, which is because of
Portal vein thrombosis associated with chronic pancreatitis.
so why portal vein thrombosis could produce sinistrial hypertension, portal hypertension. You said sinister portal hypertension.
Yes, sir.
So what are the types of portal hypertension? Are you sinister portal hypertension is the same? Is there a thrombosis of the portal vein?
The left-sided hypertension because of the liquid thrombosis will lead to gastric varices. So,
Which thrombosis? Which vein thrombosis?
Splenic vein thrombosis, sir.
The splenic vein, na? So you are saying because of the portal vein thrombosis. So it is more common is splenic vein thrombosis rather than.
Splenic vein thrombosis.
So how do you, why do you think that there is a 6 kg weight loss in last 6 months? That in last 6 months there has been 6 kg weight loss, and this
Yes,
is
sir.
started about 3 years back. But weight loss is only in the last 6 months.
Yes, sir. Sir, it could be the disease which is progressing. Initially, it was asymptomatic to begin with, and now in the like 6 months, there is a loss of. There could be disease progression, fibrosis leading to steatorrhea, leading to malabsorption and weight loss.
Okay. Then you also said that during the pain period he is having loss of appetite. How does it correlate?
It doesn't have loss of appetite, sir. Only during the pain episodes there is loss of appetite.
You can frame it other way. Is it fear of the food because of the pain?
Yes,
The
yes, sir.
loss of appetite is a significant issue. It's not loss of appetite, it seems. It should be when you are saying only during the pain, then it should be that he must be fearing of the pain, and that's why he is not able to take, or because of the frequent episodes of the pain. And that too is it because of the this pain is usually after the food, as you said in the beginning. So that's why he might not be taking because of the fear. So you did not clarify whether the pain is with every food, or did he try to change his food habits, because if some particular food is causing pain, then he would like to change the food habit.
The patient doesn't get history of any modified diet for the same. He's on normal regular diet only.
So in a patient who seems to have suffering from a chronic disease, when he starts having this change in the symptomatology and loss of weight, what are the other things you suspect? Get my
Sir,
point?
yes, sir.
What are the other causes of the change in the character and loss of weight?
There could be, sir, associated recent development of malignancy, which can be associated with weight loss, or any disease progression which is causing partial obstruction to the GI lumen, where the patient will modify the diet, and thereby there will be.
But in the history, you did not tell about the patient is having the symptoms, sign and symptoms of partial abdominal obstruction. Is it?
Yes, sir. We only gave history of nausea and occasional episodes of vomiting episodes, only during pain.
So and what about the pain in the whole history? You did not very classically describe the classical pancreatic type of pain. What is pancreatic type of pain?
Pain which is confined to the epigastrium, radiating to the back, and which relieves on partial relief on bending forwards. And
Is it present classical in this patient?
no, sir, didn't give history of pain relief on bending forward position.
It may be that nobody asked him. Is it also a possibility? So what about the? You said that this patient might have a pain of the peptic ulcer. Which type of peptic ulcer can produce same type of pain?
Sir, posteriorly located peptic ulcer, which is penetrating type.
Keep penetrating. Yes, that is a good answer. So these are the questions one should ask when you are seeing a patient of the chronic pancreatitis. So by the history, it seems it is very very classical. What are the other problems we should ask when you are asking this type of things to the patient in a chronic pancreatitis associated? One is you said melena. Another you said that there may be partial obstruction. Any other point you would like to know?
Any history of jaundice, sir?
So jaundice or even pruritus are okay.
Pruritus. Yes, sir. And any epigastric fullness, sir, or lump which previously patient had noticed.
Yes. So these are very very important. Why fullness, because of what?
The patient would have developed pancreatic pseudocyst, sir, as a
Pseudocyst.
complication. Pseudocyst of the pancreas during any previous pain
So these
episode,
are very
during the acute
important
episode.
points related to the disease process. So patient might develop pseudocyst. What is the incidence of pseudocyst formation in a setting of chronic pancreatitis?
Not sure, sir, or not sure, sir. 20 to 30%.
Even more. So these are how they are called as in a pseudocyst setting, in a pseudocyst. being present in a setting of chronic pancreatitis,
Yes, sir.
you call it what? Chronic pseudocyst. So
Mm.
how they are different from the acute pseudocyst?
Usually there will be no communication between the ducts, sir.
In
And
two,
there will be and there is
which one there is no communication? Acute pseudocyst or chronic pseudocyst?
so chronic pseudosis, and there will be
Reverse your answer. The chronic pseudocyst usually they are having communication, but acute. That's why you are draining so many acute collections. Acute pseudocyst usually you don't find persistence of pancreatic fistula. And when you are having a chronic pancreatitis, usually don't prefer to drain external because most of the time it is associated with the communication with the main duct or even side branches. So I think at this stage I agree with you that this is patient is having 20 years male. He's a smoker. He's having this type of symptoms. So our most probable diagnosis would be chronic pancreatitis. We are not sure, to my mind, whether he might have developed some sort of malignancy because 6 kg weight loss is a in a 3 months is a fast losing weight and
yes, sir.
he started 3 years. I am only worried that you said that if he was admitted in a hospital, that is within 3 years, but you said it in the past history. It comes in
Yes,
the
sir.
present history. It comes in the present history. So admission is in the main same setting. Pain started 3 years back. It has its own course. So he did not tell about that this pain is affecting his profession. These are very important points. Is he able to
Yes,
perform his duty, whatever he does? He's carpenter. He's
yes, sir.
carpenter. So what
Yes,
about
sir.
learning process? Well, frequent, is he able to perform his duty? Why is it important?
Sir, it indicates the severity of pain, sir.
So it also helps in decision making regarding the management when you are going to manage this patient. So all the history we want to know because at the end we have to manage the patient. The
Yes, sir.
history is important because of these issues. That one is that in making diagnosis, and second is that how you are going to plan the management of this gentleman. So let's go to the examination now.
On general physical examination, patient is well built and was poorly nourished with a ECOG performance score of 1 and BMI of 17.8 and vitally heart rate of 78, BP of 128 by 76, saturation of 97, and there was no pallor icterus or pedal edema. For the oral cavity examination, there was tobacco stains were present. Abdomen examination, on inspection, abdomen is flat with umbilicus central and inverted in position, with all corresponding quarters moves equally with respiration. There is no visible lumps, scars, sinuses, or engorged veins. Hernial orifice were normal. External genitalia appears normal. On palpation, abdomen was soft. At the time of examination, it was non-tender, and liver and spleen were not palpable, and there was no other palpable lump present. And hernial orifice and bilateral renal angle was normal. So there was no not tender. Percussion, there was no free fluid and liver dullness with starting from fifth intercostal space with liver span of 13 centimeter in the mid line. The rest of the abdomen is tympanic. Auscultation, he had a normal bowel sound with and rectal examination. Sphincter tone was normal with there's no melena or there is no greasy oily stool. And systemic examination was normal. So examination findings were really unremarkable, sir, in this case.
So you have one very important finding. Why are you saying it is unremarkable? You have said that nourishment is poor. What type of nourishment assessment has been done in this? Just saying that nourishment part is not good, is not enough. What are the things which have been assessed to say this?
Yes, sir. There are we have to look for the one is the weight of the patient, BMI, and head-to-toe examination. Look for any signs of vitamin deficiencies, like
You have read any nutritional risk assessment or nutritional index? Any one of the nowadays we are every time we talk in the history presentation, especially when you are documenting that patient is having poorly nourished. You have to know vitamin level biochemical. What are the clinical way of assessing the nutrition? Are there
yes,
some? There are many scales provided. Which one of the scale you will use, and what are the different parameters which are assessed? to see the nutrition?
Clinically, mid-arm circumference, skin fold thickness, and weight and BMI, and
BMI is not
other.
restricted always. Suppose somebody is coming with BMI of 27 and another person is BMI of 22. Which one is more nourished, properly nourished? With a height of 5.5, 5 feet and 5 inches. BMI is one way of looking at it, but it's not a predictor of the nutrition, is it?
Yes, sir.
Then,
Mm.
so my way of telling you this is that you must know that is that you have seen that in 3 months 6 kg weight loss.
Yes, sir.
That important in terms of talking about nourishment, and there are so many bedside tests nowadays. You know anything about?
Yes, sir. There are scoring systems, sir. Must score and
You can you can
Nutri score.
you can see these patients in the ward. And what about you have read anything about sarcopenia assessment?
Sarcopenia, yes, sir. That is based on, we can do clinically, sir, either by ultrasound, either based on clinical and also exam by based on imaging findings.
Mhm.
Like whenever there is we get a CT of the abdomen, you can look at the psoas muscle thickness to,
You have heard of global health assessment?
yes, sir, global subjective
So
global assessment.
subjective global assessment. So that's why so these are the things we must know, because certain things you can do on the bedside, certain biochemical things made a patient, because until unless you know the things you will not prepare the patient. Second important thing you mentioned about ECOG one. ECOG is what? What is ECOG?
So European oncology group consists of
What is European Oncology Group? It's not a OG, then EOG it should be there. Why it is ECOG? And
European
was started for what? For what
European
purpose? What purpose this one was started? You know this or not?
no, sir.
So it was started for the oncology, not for the benign disease, but in for the in every meetings we talk about this, and they say ECOG is usually it was started for the oncology to assess the what is the status of the patient at the time of the presentation. So it's not the synonymous in every patient. We should not be used. Otherwise, this question may be asked to you, and you should, when you are using any terminology, you should know total why you are uh, uh, using this terminology. And it is not also European. It is but in our it is it is external corporative oncology group which was started this assessment for the patient with the cancer, not for the ECOG. So, so this I mean to say that this patient, when you are, as I said in the beginning, when you are taking the history, when you are examining the patient, we are also planning for the management. Our aim doesn't finish with the history taking and examination presentation. So whatever we do with the intent that this patient is going to be operated, and I have to prepare the day you see the patient. So as you said, nothing has been added except that you said nutrition is not good. So how will you proceed in this, gentleman? You are sitting in the OPD, you got
Yes, sir.
this man, and now you are going to manage this patient.
Now I'll ask the after resident examination, sir. I'll get basic investigation to look for his nutritional status.
Hmm.
That is by serum albumin or hemoglobin level and
Okay,
uh,
those are the those you will start with tell me one, two, three. These are the things I am going to do. First thing you do, you are sitting in the OPD and you have made this diagnosis. What is the first thing you are going to tell the patient?
so I'll tell the patient that is the probable um, what could be the cause of his illness, and then I'll ask the patient. I'll review the medical records of the patient, whatever the patient has previously received treatment,
Mhm.
and
It is quite
then
you have
based on that, I'll further investigate.
it is quite clear that he has received the painkillers and pancreatic extract by your history. So almost clear that he has received this treatment. What are the things you are going to suggest?
So, sir, I'll like to confirm the diagnosis, sir, by investigations.
I'm sitting in the OPD. In place of you, I will say that first of all, you stop your smoking. Do you agree? You have written that he's a chronic smoker. He is smoking some. I don't remember exact the number. So does it play
Uh,
a role in etiology of the chronic pancreatitis? By any role of smoking?
yes, sir. Smoking is a non-etiological factor for chronic pancreatitis. It can be independent factor also, and it can be a contributory factor along with the alcohol intake.
So after
So,
history, after examination and history, how confident you are that this patient is suffering from chronic pancreatitis?
uh,
90%.
yes, sir.
So 80%, 90%, 80% we are sure. We can have another lesion in the pancreas in terms of malignancy. Usually we are almost sure by clinical examination testing that he is not suffering from being peritoneal cancer, all those things. Most probably it is chronic pancreatitis. So and that and based on that, we can our first duty is to tell in the OPD that stop your etiological factor. If there is alcohol, stop it. If there is a chronic pancreatitis, everything will stop it. If you are in the south, what more you will ask? If you are
Uh,
working in a particular belt of Kerala, Andhra, and Tamil Nadu and Karnataka, there is a belt. Then what will you ask them?
uh, the history of tapioca ingestion consumption.
What type of material is present in that we have produced? What is that? What is that by? If you have to describe the type of consumption, what is that thing they are taking? Is it a fruit? Is it a seed?
It is a root, sir. Uh, Plant root tapioca. So it has got a kind of cyanogen, sir, which promotes the pancreatic fibrosis.
Tuber and root. You are aware of tuber and root? Tuber.
Tuber, yes, sir. Tubers.
So it is a root or tuber. So
Mm.
now, though there are lots of people in Kerala, also people say the alcohol is more than Punjab. So nowadays there are question mark on the role played by the tapioca, but still we must know. And if you are working in the south, you must also ask about the what is happening in the adjacent area in the villages. Are there more people suffering? How it is different, Doctor Vinay? When it is in if you are suppose you are making a diagnosis of tropical chronic pancreatitis, we say this chronic pancreatitis, which is alcohol related or other etiology, how it is different? What are the different points? Some differentiating features. In
Yes,
India,
sir.
you must know this.
Yes, sir. Tropical pancreatitis usually starts at the younger age group, sir,
So,
and
younger
it
is
is
one. Second,
uh, higher chance of malignant predisposition in tropical pancreatitis than
third,
in alcoholic pancreatitis,
third,
and it is also
we start in younger age. Second is higher chance of malignancy. Third,
progression of disease is also faster in tropical pancreatitis.
more important, more than progression. So malnourishment is very, very common.
Malnutrition. Yes.
Malnutrition is very, very common. So they are younger, they are poorly nourished, they are having more chances of malignancy, and on examination, duct canal is nicely dilated. So this patient will come in the OPD and try in the OPD by seeing the patient one. So these are the certain salient features by which we can differentiate from the chronic pancreatitis to the tropical chronic pancreatitis, which is obviously common in our country, so we must know it. Not only in our country, other areas also. So this is very, very important. So now you tell what are you are going to do.
Uh, yeah, let get blood investigations of the patient, sir. That is hemoglobin, which is normal with normal counts, and LFT has been done, sir. LFT with total bilirubin of 0.7, and albumin is 3, and OTPT enzymes are normal. ALP is also normal.
So why are you saying
And
7.9.7 hemoglobin is normal in a young male?
no, sir, it is low, sir. Albumin is lower. It's not normal, sir.
Hemoglobin we are talking about.
Hemoglobin 9.7 is also low, sir.
Does it come into
For-
anemia? No. Will it fit into the diagnosis of anemia? You can clinically. So there is some problem in the clinical examination. Otherwise, 9.7 hemoglobin should be called as anemia or not.
yes, sir. It should be less than 10 anemia. It should be called anemia.
In a male, in a female, it is different. So,
Yes, sir.
as a surgeon, we cannot forget the basic things. You remember, don't always think that I am a surgeon. Only knife is my friend. So you have to know the biology, biochemistry, and microbiology, certain important areas, pathology. The surgeon has to know everything. Then only you can manage a patient properly. So if I have to say, I will say that there is anemia. There is no suggestion that there may be some obstruction in the bile system. And it seems that albumin is low. So as you said in the beginning also that there is some sort of malnutrition, and that is pointing towards malnutrition because 3 albumin in our country, though it's borderline, but it will be taken as a hypoalbuminemia. This is very, very important. What other things you want to know? So these are our aim in a presentation to make the interpretation of the data provided.
Sir, I would next go on ask for X-ray abdomen, sir, but patient came to us with the ultrasound report. It was done from outside.
So you
Uh,
arm inside that I can do X-ray abdomen. What are the things you find? You do some specific X-ray or any X-ray abdomen you will send and you will get the report what you want.
no, sir. X-ray erect abdomen with in a prepared bowel, sir. Like,
Prepared bowel is very important. Lots of gas inside. There is to be some
yes,
terminology. So have you not seen any X-ray abdomen nowadays? People are not doing, or still you can see. Sometimes for the clinical purpose also we take the X-ray, one X-ray, good abdominal X-ray, by asking patient to take, but not the prepared, but usually we should prepare that there should not be lots of gas in the abdomen. So there are certain agents you to give some laxative and he prepared and then only do it, then only you will get the picture. Some focused X-ray in the projecting to that area. There is some name given to that area that you project to that particular area, not that you take the abdominal X-ray as you take for any other obstruction or something. Go and project that area and concentrate, and then you will find some sort of classification you can find. So X-ray abdomen is a good investigation in a patient with a chronic pancreatitis.
this patient had come with the outside report of ultrasound abdomen, sir, which says liver is normal echo texture and there is no HBRD, CBD diameter of 4.3 mm, and gallbladder is there is no calculi, and wall thickness is normal. Pancreas, there is head is almost 3 centimeter and body 23 millimeter, and tail region it is 20 mm, which is increased in size and with irregular contour, and the parenchymal echo texture is increased with the dilated pancreatic duct of 10 mm in the head region, 8.5 in the body, and there is multiple calculi noted, and there is, however, there is no free fluid or peripancreatic edema, and the rest of the findings were normal, sir. So the impression was chronic active pancreatitis with dilated pancreatic duct.
15.5 centimeter, is it okay? Or do you think that this is a little bit of hypertrophy? But equally tested normal. Size of the liver. 15 centimeter on the ultrasound, is it okay or slightly toward the higher side?
Slightly on higher side, sir. 13 around.
So now you have found this in your diagnosis is confirmed that this patient is having all these features, and anything we are happy with this, and we should try to find more details. So if you have to say, you will say because our suspicion was also mass lesion. You can say that there is no, as we suspected, ultrasound doesn't suggest any mass lesion, and splenic and portal veins are normal, so we are not suspecting any type of portal hypertension. There is no free fluid, so what are the other than portal hyper, sorry, other than pseudocyst, what are the other regions of the free fluid in the abdomen in a chronic pancreatitis.
Sir, pancreatic ascites is also
And
possibilities.
that also can produce malnutrition, and it's because of the some rupture of the duct somewhere in the periphery or something. So pancreatic ascites, which can produce other fluid effusion also sometimes. So these are the things we must know when we are talking about doing these things. And in the examination also, we forgot that certain things which are fat it took in are not absorbed. So fat soluble vitamins have also maybe decreased. So that's why nourishment component has multiple things in that. So now what?
Now, the patient lipid profile has been done, sir, which was normal, and with the serum amylase lipase were normal, with the fasting blood sugar of 75, and HbA1c is also normal, sir, 5.2. With the fecal elastase got, sir, which is low, that is 40 microgram per gram of stool. So there is a exocrine insufficiency associated with in the patient, sir.
But endocrine you have supplemented, but still there is no benefit to the patient. Has he benefited by the supplement of the pancreatic extract?
No, sir, is not benefited, sir. Patient was also on irregular PRT, and dose is also maybe suboptimal.
So that what are the optimal dose in the patient?
Optimal dose is 25,000 to 50,000 with each meal, and 10 to 25,000 international units in with every snack.
So very high doses are required. And what are the precautions to be taken for complete absorption?
It has to be taken along with the meal, sir. And
What happens if stomach is acidic? So pharmaceutical people say this doesn't have this type of thing, but we should always add PPI because with this absorption decreases when there is a acidic environment in the stomach. So these are the things, and lipid profile is normal, so we are not suspecting alcohol he doesn't take. What about other things we should try to look into? Hyperlipidemia is not there.
look for hypercalcemia, sir. That is calcium.
Very
Calcium
important.
was
Very important. Before labeling anybody idiopathic, we must look into all this. Calcium normal. I did not see report of the calcium. So these
it
are
was
the,
it was normal, sir. 9. It was
so
9.2.
we should also try to look into all these features when we are going to say that this patient is having what percent of the people will not have any etiology.
Uh, Around now it is maybe now the percentage has reduced recently because of more genetic factors has been included.
What percent I said? I did not ask that what has been the genetic factor.
I don't know, sir.
About 20% still will have this thing that idiopathic 15 to 20% people will not be able to diagnose. However, we have to manage this patient based on the project. So now what?
Now, sir, to get a CT abdomen, sir, to look for the
Okay, so you see contrastinal CT scan abdomen, but what will you tell to the radiologist when you are doing a CT for the chronic pancreatitis?
radiologist request for a plain CT along with pancreatic protocol.
Yes, very good answer. Plain CT is must in this patient to look into the history, which is more better evaluation can be done on X-ray abdomen, and calcification can be seen better, or it is better in the CT.
Better in CT, sir.
Yeah, CT is better than the X-ray abdomen. Most of the people think that CT is not CT, so that's why if, calcification is better seen on CT scan. So the plain CT is very important. So has it been done? So you have
Yes, sir.
to see
I have
what are the things you would like to see in the cities.
when I look for the sorry, I look for the pancreatic duct size diameter and the distribution of the calculi, whether it is intraductal, there is any parenchymal calcification, and
Not see the
there's a plain CT.
plain CT. You should start with saying that I would like to look into the plain CT scan. What are the things you would like to look into the plain CT scan?
The presence of any calculator is there.
So you could see this.
Yes.
Good I'm describing. Where are you now and what are you seeing?
There are multiple numerous calculi which is there present throughout the pancreas, sir, including the head and tail region. And
So that is also the side branches also seem to have some sort of like this is very important.
yes, sir, there may parenchymal and
Yes.
is they're outside the ductus.
Certain classification is beyond the duct also. So you should know all these things because you will try to take as much as possible, but all the side branches may not be opened, and that's why if in the post-operative period somebody did a CT scan, they will say that stone is left. So this is very, very important. Go ahead.
So this is a image of the portal facer, which is also showing there's a ductal dilatation with presence of numerous calculi within the parenchyma. However, there is no mass lesion noted, and the splenic vein and portal vein appears to be normal, sir.
What about the head? Bulky. There is no pancreas in the head. What about the head area?
Head also numerous calculi is there, sir. However, there is no any hypotense lesion seen or any mass lesion seen.
It's not, doesn't seem to be bulky also. Portal vein, splenic vein seem to be normal. So now tell me what are you doing?
Now, sir, now we have to, sir, since the patient is already on IV analgesics and with increased IV requirements of analgesic and with more severe pain, the frequency has also increased. So we have to offer for plan for surgical management for pain relief, sir.
So this patient is still smoking. You will not prepare him that he stop first. The component of the what are the components of medical management? We are not talking still about endoscopy. What are the components of medical management?
First, sir, foremost is the to cessation of alcohol or smoking, and
That is most important thing. Then after that,
the uh, analgesic, sir.
proper analgesia, smoking of the alcohol. I think if it is like stopping of the smoking at all, 100% stopping of the smoking
And enzyme replacement.
enzyme replacement, which is. Have you read any article regarding the efficacy of the enzyme? What percent of the people will definitely benefit, and is it 100% working, or there are some ifs and buts about the supplementing the pancreatic?
They say, sir, uncoated preparation works with pain management. Otherwise, entry coated preparation for mainly for the absorption, counter the malabsorption.
And in spite of all effort, it has been found that there are multiple studies suggesting that every patient of the pancreatic extract doesn't benefit from the supplementation of the extract. So this patient you are saying straight away you take for surgery. However, I would suggest that every time we take this patient, we should just give some management or try to see how many months he has taken the treatment, what are the prescription he was already taking. These people, they are sometimes getting lots of additional injection because of the pain when diagnosis is not made in the periphery. So they start taking morphine and all those things. So we must also look into what are the prescriptions, medications he is taking. Does he require any type of psychiatric evaluation for some sort of addiction? Because it is very, very important in our country, especially every country. So this is a component of the management, that evaluation of the what prescription he is taking, and then modification of the diet also. Modification of the diet is a very important component. What he is taking? Is he taking lots of fat? So that we should motivate all these things and then think about going for any type of surgery. But If you go to endoscopist, will he send you directly to the patient? Let's assume that proper medical management has been done, which includes point-wise cessation of the smoking, avoiding of the alcohol, stopping of the alcohol, modification in the diet, modification in other habits, then
Yes, sir.
back to the adequate analgesia and adequate replacement of the pancreatic extract.
Yeah.
All these things are the component of medical management. Once it is done, 1 or 2 months, then you are going to talk to the patient. So, will you discuss with your medical gastroenterology friend, or you will straight away go and operate?
Sir, endoscopic management in this case, sir, since there is the calculi is predominant, if it is involving predominant in the head region, then I would have asked for medical management, I mean, endoscopic management, because it is present diffusely throughout the pancreas. So, unlikely endoscopic management will help in this patient.
So, you are aware of any Indian classification of the rule of endoscopy? These are the patients who benefit by endoscopy. These are patients. Now, let's not go into trials. First, you are aware of any Indian classification of the endoscopic need for endoscopy first, then surgery? Can you
No, sir.
know?
No, sir. I'm not aware, sir.
So you go and read today that the publication by the AIG, Dr. Nageshwar Reddy Group, they are classified based on the MRCP, RERCP, the criteria to whom they are going to do the this management. There should not be multiple strictures. There should not be, as you said, head prominent disease and stricture free disease, and usually there should not be disease mainly in the body and the tail of the pancreas. Otherwise, they are saying we can remove all the stones, and stones are so. If I have to say, so endoscopic management. Any other region you can say other than that Dr. Nagi's publication, or any other reason you are saying that I will go straight away surgery, early surgery with this endoscopy, then surgery. You are
Yes,
aware
sir.
of any study where it has been emphasized that we should go for surgery rather than after medical? Let us be very clear that this is after adequate pain management by doing all the medical components of the medical management by supplementing. Then, even then, the patient is having, there are certain indications. Any complication of the chronic pancreatitis, it is not here. What are the
Yes, sir.
other reasons you are subjecting patient for the surgery?
One trial which I had published, the ESCAPE trial, which compared the endoscopic versus early surgical management for chronic pancreatitis, which showed uh, early surgery benefited the patient in terms of better quality of life and pain free in the post procedure period.
So, trial
There's
escape trial, what was the drawback of escape trial?
numbers were small, so there were only I
What
think
about
40 or 50 patients were included in the study.
follow
Follow up, not aware, sir.
Because escape trial, the another this thing has come for a longer follow-up. It was criticized for the having a smaller follow-up. Any other trial before another very important trial which comes into a class one trial. You are aware published in NEJM.
No, no, sir.
First trial which was a very scientifically very high grade trial was published from the Amsterdam group, and they published they randomized into endoscopy with surgery once medical management was done, and this it was published in NEGM. Then it's again same follow up was research, so they again published in, I think, in the gastroenterology, and then again they published their follow up of more than 7 years, and it has been found that the people who have been subjected to the surgery early have better quality of life, long-term pain relief, and also the cost of the management is lesser. So this is very, very important. The large follow-up escape trial also has come up. So you should go and read it. So you are prepared for the surgery, your patient. What all are you going to discuss?
Well, explain the patient that after the will not even after the surgery the calculi may remain, sir. Not all the calculi we cannot able to remain, we cannot able to remove. So and there is still the possibility of pain may be there in the patient, and requirement of again analgesic and other additional intervention for pain management may be required.
Percent wise. So what procedure you are planning in this patient? Suppose you have planned for surgery. There are multiple procedures. So which procedure you are planning in this?
Since there is a calculated distribution which is present in entire pancreas, including the head and body tail, so phrase procedure is better procedure for this patient.
So what is the outcome of phase in 5-year follow-up? What percent of the people will pain? We are going to do a phase procedure. So before going to tricks of the phase procedure, we have 3-4 minutes more. So what are the follow-up? You must know the follow-up, because then only you can go. You are going to describe. So look, I am going to do this procedure. These are the issues with the procedure because these people are young. And then, if you tell everybody you might have a pain relief, pain maybe occur again, and you might have these things. So then nobody will get the surgery done. So how will you describe that this patient, you are going to have this percent of the people will have 5-year pain relief. These are the things will be controlled. These are the things we cannot control. So suppose he asks you, Doctor Vinay, I'm losing this fat in my stool. So can I my fat be get reversed? So what will be your answer?
No, sir, I'll explain the patient that patient even in spite of surgery he has to be on enzyme replacement with diet modification.
I will ask patient that don't take fat, lots of fat in the diet. So usually fat-free diet will do. No need to take fat after certain age, the group of the people. So so that is, but you have to tell that the passing of that is food which you are doing, if you are taking fatty diet, it is not going to improve. That is
So,
one. Suppose somebody is diabetic, he will ask you after your surgery, will you be diabetic free? Then what will be your
uh,
answer?
diabetic may even diabetic will not improve, sir. Diabetic will even worsen after surgery.
No, worsen is usually not a correct answer. It's not doesn't worsen. Either it deterioration will get slower, or it usually the insulin doses are decreased.
So
Uh,
dependent.
it's not that worsen. So if you all tell all these things, nobody will get your surgery from you. So this is very, very important to know that the worsening of the diabetes is slower or it stops. The dosage of the insulins are decreased if you have done a good job, because and pain relief obviously. So so these are the very important factors. So what is the how does head coring helps in the pain management?
Sir, head is considered to be pacemaker of pain, sir. So the removing of head coring, uh,
Head coring helps in the pain management because it's supposed to the pacemaker, and this type of result you cannot get in the lateral pancreatitis diagnostic as well as in the by doing the stenting and removing the stones, doing the lithotripsy. There are multiple things being done by endoscopy. So the patient usually, if you go to them, they will try everything. Then only patient comes. I think I'm not going into technical details. We have been able to cover. I would suggest you to go to do 2-3 articles when you are answering in your exam. If you quote these articles, it will be better, because the clinical diagnosis is almost sure. We were sure. So with this, I think if any other question you want to ask, or we can. Dr. Nagar is there. We can close. If you want to know anything, you can ask, or anybody which I think about 10 people have joined. So anybody wants to ask any question, we can discuss, or else I will just
the second paper which you told, sir, that I will get.
second paper you must know in NAGM. It is NAGM chronic pancreatitis. It is a RCT. and the follow-up of the script are also has been recently published. Very
Okay, sir.
recently, it has come again by having longer follow-up. Like same thing, same that follow-up NEGM article, the criticism was saying that follow-up is very less. One more article you can go is also published regarding when you are doing surgery after failed medical management. The wound infection, the leak rates, all those things are more in comparison to the patient when you are going to straight away. This is also very important to know that suppose somebody says, I will do endoscopic management and you can do later on the surgery. So that is also one of the things. But we are seeing that most of the people, they go for medical management because people go to them. And mostly when patients come to us, they are already medically managed. Something has been done. So these are the concluding remarks. Any other query or we'll close the session?
Okay, sir. Thank you, sir.
Okay, Anand, for the,
Okay, sir.
okay.
Yeah, we can close the session at 8:30. Thank you, sir. Thank you for the moderating session.
Thank you, sir.